Dr. Ajit is going to start with primary angioplasty, how I do it.
I'm going to talk about the way I do primary angioplasty. I will basically discuss this topic under three headings. One, the technical aspects. Second thing is I will discuss some literature wherever I think it would be relevant. And at the end, I would show some cases which I have done. The primary aim of doing a primary angioplasty in acute MI is to achieve relief of chest pain, resolution of ST segments, achieve TIMI-3 flow with a good myocardial blush, which indicates good tissue perfusion. Now, the whole process starts in the emergency room. When the patient arrives in the emergency room, you have to make a decision as to whether perform primary angioplasty or giving thrombolytic therapy. Now for this, there has to be a person in the emergency room who can discuss the risk, benefit and cost to the patient. And this is sometimes logistically difficult, particularly at odd hours. But if you devise a system whereby this is possible quickly, this can be explained to the family and the appropriate decision can be made. In our hospital, we have a deferred payment policy because nobody comes to the hospital with a serious condition like MI with money in their pockets. So basically, you have to tell them about, this is the likely expenditure, and they generally end up paying their bills later. Quick IV access, preparation of the parts, and consent has to be taken. And we generally take separate procedure and expenditure consent. We do it separately. As far as antiplatelets are concerned, in our hospital for the last 4 or 5 months, we load the patients with ticagrelor 180 milligrams or prasugrel 60 milligrams. Many times patients are referred from somebody outside and they have received clopidogrel. Now, if you are sure that they have received clopidogrel load, but if it is within 5 to 6 hours, we generally reload them with ticagrelor or prasugrel. Now, this is not based on any clinical trial or evidence, but just because clopidogrel acts a little more time to be in the system, we make sure that the patients are fully loaded with antiplatelets, and we give chewed aspirin to all. Now, adjunctive antithrombotics, in our hospital, we have a standard protocol of bivalirudine with bailout GPA as a standard at our institute. Now, this is very important because giving antiplatelets before bival is extremely important, and that is why in the previous slide I mentioned that we make sure that patients are fully loaded with antiplatelets because bival is the default anticoagulant in our cath lab. I use GPA if I'm contemplating multivessel PCI or I see a large chunk of thrombus in the artery visibly. Now, just a brief discussion about bival. All of you know that after Horizon AMI trial, which studied patients with acute ST elevation MI, they were randomized into bivalirudine monotherapy versus heparin plus GPA, and almost 1,800 patients were randomized in each group, and at the end of the study, after a month, they saw that the net adverse clinical events, which was a combination of MACE and bleeding, was much better with bivalirudine. Now, when they dissected this out, it was clearly seen that the difference was mainly driven by major bleeding. Bivalirudine causes significant reduction in the bleeding episodes, but the major adverse cardiac events, which include death, target revascularization, MI, stroke, they remain almost the same. So basically, the MACE rate is no different, but the bleeding rate is significantly reduced. And it is important to remember that 26 out of 93 deaths, almost 30%, in this trial occurred after a major bleed. So bleeding in this setting is an independent predictor of death by some mechanism. Now, this was the 30-day mortality, which was in favor of bivalirudine. This was 30-day cardiac and non-cardiac split mortality. Cardiac mortality was significantly lower in bival. group. Now this was one thing which was stressed at that time, that the incidence of acute stent thrombosis was little higher with bivalirudin, but it is important to remember, and subsequent studies have shown that if the patient is fully treated with antiplatelets before, if you give bivalirudin for 2 hours completely after the procedure, in this trial the bivalve infusion was stopped immediately after the procedure, but it is always advisable to continue it for 2 hours. And if the patient had received heparin beforehand, this incidence of acute stent thrombosis was not a big scare. As far as the protocol is concerned, we use right femoral approach, 6 French sheath in all, because all balloon stents and aspiration catheters are compatible, almost all catheters are compatible with 6 French. No venous sheaths unless conduction defects if there is a conduction defect with hemodynamic compromise. I use metoprolol if heart rate is more than 100 with good blood pressure, and a non-infarctilated angiogram is first performed, and then we go with an infarctilated angio with the guiding catheter straight. As far as the guiding catheters are concerned, for the left coronary catheter, I prefer to use EBU or XB. My personal feeling is the EBU, which is a Medtronic catheter, is good for the small aortic roots, particularly for Indian patients, and it is a less stiff catheter. For short left mains, I go with the Judkins left. Right coronary catheter, for the right coronary artery, you use the JR, the Amplatz left or right, or the IMA catheter. For the SVGs, the Amplatz multipurpose or the left coronary bypass catheter, but always avoid using a JR for the SVG because it's good for diagnostic studies, but when you try to do an PCI, many times it doesn't provide adequate support. IMA catheter is preferred for the Limas. Guide wires, this is not a strong recommendation. This is everybody's personal choice. I generally go with hydrophilic wires like BMW, Whisper, Choice PT, Extra Support, or many times these days I've started using the CrossFit guide wire by Abbott because many times it becomes very easy to cross with CrossFit, particularly if the thrombus is little hard or the material is little hard. I use a loop and push technique simply because you cannot see anything beyond the obstruction. Many times it's easy, if the guide wire loops, it's just easy to push it distally so that it doesn't pass into any branches. It's important to watch the wire tip during catheter exchange. If you have to exchange the catheter, make sure that you watch the tip of the catheter because it can inadvertently perforate the vessel. Generally, if the guide wire opens the vessel and if you see the distal vessel cleanly, I generally go and directly stent the vessel without pre-dilating with the balloon. These dilatations and passage of catheters many times result in dislodging the thrombus material distally and results in slow or no flow. So if I see the vessel distally, a clean vessel distally, after initial passage of wire, I directly stent it, and this does happen quite frequently. Now, a very important thing about thromboaspiration. Until 2006, most of the thromboaspiration catheter trials showed borderline results or ambiguous results, showing that it doesn't really help. The first trial which really showed significant benefit in this setting was a TAPAS trial which was published in 2008, and it showed that by the use of export catheter in the setting of acute ST elevation myocardial infarction, the acute results as well as the long-term clinical outcomes were better when you use this catheter. It is important to remember that in this trial, in both groups, when thromboaspiration catheter was used and when it was not used, the TIMI3 flow rates they were equal in both the groups. However, the myocardial blush grade and resolution of ST segments was significantly better when the thromboaspiration catheter was used. So TIMI3 flow is not the end of it. There is much more beyond that. This was the survival curve which showed that with thromboaspiration catheter, the patients did better. Now, with techniques, there are number of thromboaspiration catheters in the form of export, the TVAC, and the thrombusters. In general, the kinking is less with catheters with a stillet. So I prefer to use thrombustor. It is very important to advance very slowly, particularly in the proximal parts and the curves of the catheter, in order to avoid the kinks. Perform 2 to 3 passes with pulled and locked piston, and many times, with the same catheter can be used to give nicorandil or nitroprusside or adenosine deeply into the artery to improve the flow in situations where you have no flow or slow flow. It's very important to remember the spasm is very common after thromboaspiration, particularly after multiple passes, and it can give you an appearance which can be little deceptive. Most important is when you do thrombosuction, you must let it back bleed after each run, because you might have pulled some thrombus material in the catheter which can come back with the back bleed. Pharmacotherapy of slow flow, it's very important. It's not uncommon. It's fairly common to have no flows and slow flows in this situation. In my cath lab, I use nicorandil as the most common pharmacological agent in this situation. Of late, we have also started using nitroprusside. Diltiazem and verapamil and nicardipine can also be used. Adenosine I do not use in right coronary arteries. I prefer to use it in the left system. I've read some articles about combination of adenosine and nitroprusside being very potent, but I have not personally used them. Deep intracoronary use of aspiration catheters and injection deep into the artery is particularly useful in very slow flow or no flow situations. Because if you give these injections in the guide catheter at the coronary ostium, they will never reach the target. Another thing which I thought is important is I avoid post-dilatation if there is slow flow after stenting, because many times sometimes better is the enemy of the good. You try to after getting some slow flow, you try to dilate those vessels, and then you end up having no flow because of the material is squeezed further and goes distally. A few words about nitroglycerin, nitroprusside. Nitroglycerin, it acts on the epicardial vessels, and it has little action on microvasculature. So in no flow or slow flow situations, nitroprusside is a much better drug, because it directly gets converted into nitrous oxide and acts on microvasculature, while nitroglycerin is converted to nitric oxide by the epicardial vessel wall and acts locally. So it's good for spasm, but not for slow flow. Now there are some dilemmas during PCI, what to do with other lesions, how to deal with side branches, and how to deal with surgical disease. Other vessels, you deal with other vessels if there is persistent hemodynamic instability, persistent chest pain, persistent ECG changes, or you perceive an imminent closure in other vessel. Otherwise, the wiser dictum is leave those vessels alone at the time of primary angioplasty of the culprit vessel. Side branches, I generally wire if its branch is large, stent the main vessel and POBA to side branch. Slow flow in side branches after main vessel stenting generally improves with time and nitroprusside nicorandil. Rarely does a patient die of disease in the side branch. So this is important to remember, that don't chase the side branch unnecessarily unless you have to. Stent choice, again, make sure that patient will be able to take long-term dual antiplatelet therapy. Special considerations for diabetics, small vessels, long lesions, where you have to consider the drug-eluting stent. We generally use 4 questions. Is there any anticoagulation disorder? Is there any history of bleeding disorder, or has the patient suffered from serious bleed? Is the patient anticipating any surgery? And how is the compliance issue? So if all these factors are favorable, then you can use a drug-eluting stent, otherwise go for bare metal stents. Now, some cases, 50-year-old man, inferior infarct. Now, after dilatation with the balloon, you can see the artery appears very ratty. There is a lot of spasm, and there is appearance of thrombus here. You can see a filling defect. This is the thromboaspiration, and after giving aspiration and nitroglycerin, the patient is stented with a fairly good result. Now this is anterior wall MI. Again, you can see here that you pass a wire. This is balloon dilatation. After dilating, there is no flow, So you just thromboaspirate, and you can see, you can get a good, fairly good flow, and then you can, after stenting, the vessel looks pretty good. This is another patient with right coronary occlusion. Here you can see that after dilatation, you can see a big filling defect with hardly any flow, indicating presence of thrombus. I sequentially dilated it with a balloon, thinking that it may be a diffusely diseased vessel, but the flow did not improve. So at the end, we performed thromboaspiration, and after aspiration, there was fairly good flow. Now, this appearance of the vessel after aspiration is because of spasm, because if you give nitroglycerin to these patients, this vessel appears much better than what it looks in the previous views. Now, we had to put 2 stents here, and the final result was fairly good. Another case with a total RCA. Now, here you can see after dilatation with the balloon, the big filling defect here. Now, you just do a thromboaspiration, and you can get a good result. Another case with an LAD after dilatation with the balloon. There was no flow after dilatation with the balloon, but when we aspirated, after aspiration, the flow was very good. Now, in this situation, there is no point in dilating this with the balloon. You just go ahead and stent this vessel, because if you dilate, you can still, you can create distal embolization. So you get a good result at the end. This is another patient with a critical proximal LAD lesion.
Ajit, can you summarize now?
Yeah, just last couple of cases. You can see, you can aspirate, and after dilatation, you have good result. Well, I'll just go forward. Like here you can see that when you have a flow like this, you can put the catheter distally and give deep intracoronary nitroprusside, and you can, end up getting a good result at the end. I'll just skip this. Yeah, this is an interesting thing I would like to show you. Sometimes, this looks like a fairly benign lesion. You dilate it, and what happens is the thrombus goes distally and occludes the vessel here. Now, what you do is just put the suction catheter distally and aspirate the thrombus, and then at the end you can get a good result. Actually, I can stop here. We can. These are just the examples, various examples of cases. It's over. I mean, if you have any questions, yeah.
Check.
Well, whether after one day, whether you should open the artery itself is a question. But if the patient has, say, ongoing chest pain or has some indication to open the vessel, you can do your question is there any time frame, right, for thromboaspiration?
The thrombus is mature, does it really come from the aspiration?
Yeah, the later you do it, the more thrombus you are going to expect. So whenever you see a patient later in the phase of evolving MI, the more are the chances you are going to require thromboaspiration. So it's that another place where I use thromboaspiration is a failed thrombolysis as a rescue angioplasty, where you see a lot of thrombus. Yes.
Okay, one question from there.
Dilate first before doing, because all the cases you showed that you balloon dilated and then you did thrombus aspiration. Whereas we take the thrombus aspiration catheter first and see whether flow is resumed before we think of balloon dilatation.
Yeah.
Why do you do it the other way around?
Well, actually, of late we have changed our strategy. What we do, of late, what we do thromboaspiration first, and then we do the balloon. But initially for last so many years we have been doing dilatation first and aspiration later.
Yes,
but I think if you dilate first, there is a bigger chance of distal embolization,
exactly,
just because of the balloon.
Yeah,
so
your point is well taken. Thromboaspiration should be done first, without doubt. A very rare case, the lesion is so critical that the thromboaspiration catheter may not go. That may be a once in a while situation where you may take a 1.5 balloon and make a small way for the thrombus aspiration catheter. But by and large, you are right, you should do thromboaspiration first and then do stenting straight away. I think you probably you would have mentioned something, I thought, on the role of mesh stent in some of the cases. The mesh stent which is used by, I do not
M-Guard
know,
stent.
M-Guard stent,
The M-Guard stent.
which is a very good device for...
I don't have a big experience with M-Guard. I have used it in 2 patients and the experience was fairly good. The only thing is you have to use a bigger guiding catheter for using M-Guard. Usually you have to go with the 7 French. It goes through the 6 French, but it's difficult to come out. If you have to pull it out, it's difficult to pull it through a 6 French. So my experience with M-Guard is limited.
Yeah, if there is a large thrombus load which is persisting even after thromboaspiration, M-Guard stent is a very good idea. Thank you, Dr. Rajit.